Hello, everyone, and welcome to the HealthyXSundays podcast, where we bring you the most critical and actionable content in the nutrition and fitness space. Your hosts are Dave from Mind Muscle Pro and Kunal Jain, also known as Veg Diet Coach. In this episode, we are excited to welcome Josh. Josh is a clinical lipid specialist who formerly practiced in endocrinology before transitioning to a role as a medical science liaison. His PhD work focused on cholesterol disturbances in Alzheimer's disease, and although he also has a doctorate in physical therapy, he is best known for his role in teaching lipid physiology. He serves as an adjunct professor at several medical programs and recently wrote a book, The Home Security System and the Lipid Neighborhood, Uncomplicating Cholesterol and Cardiovascular Disease, which releases on Amazon on February 18th, maybe sooner actually. Word on the street is he may have a Valentine surprise for us. His goal is to help you, whoever you are, not have heart attacks, strokes, and dementia by explaining complicated biochemical concepts in a relatable way. Welcome, Josh, to the podcast, and thanks for making time.
Thanks so much for having me. This is going to be super fun.
So, Josh, what inspired you to write the home security system and the lipid neighborhood?
Yeah, so I have been teaching lipid physiology for quite a few years now, and I've had the pleasure of trying to disseminate these sorts of concepts in a relatable way to many people, whether they be healthcare professionals, whether they just be random people I'm sitting next to on airplanes, all these things, because I really care about people and I really want people to have a better understanding of what happens when pertaining to things that result in cardiovascular disease and down the line dementia, because we don't want to have that. There's a big difference between living and existing, and for as long as the good Lord keeps us around, we want to be crushing it, and that means a lot. And so people have been saying for quite a few years now, it's like, dude, you got to write a book. Oh, you should write a book, because I'll rattle off all the stuff and I'll try to use some pithy catchphrases and hopefully some salient metaphors here and there. And, people, I don't know, seem to like it most of the time. At least they invite me back or pretend to be my friend. I don't know. And so I just heard it enough. And then I was like, you know what, I should do this. And I just feel like, since it's such a broad topic, and since, everybody out there should want to have a better understanding of the factors that go into maintaining your cardiovascular health and your cerebrovascular health, hey, let's put it all down there. Let's have some fun while we're doing it. And my whole goal with this book, which, hey, this could be you soon. This is the proof. And as soon as I get my author copies today, it's going to go live on Amazon. So stay tuned for that. But anyway, so my whole goal for that is for you to, laugh a little, for you to learn maybe a lot, maybe a little, and then be better off than before you read it. And so that's the whole goal with this. And yeah, it's been fun, and it's been fun to go on various podcasts like the one you have here to talk about it a little bit more. And before I forget, so as mentioned in the introduction, I am a medical science liaison for Amgen, but all the things we're going to talk about today are completely independent from Amgen, and the opinions expressed are my own and do not represent the strategies or perspectives of Amgen. So now that caveat is out of the way, we can have absolutely unadulterated fun and talk about whatever we want to talk about.
That's awesome. So, you have an extensive background in endocrinology, in physical therapy, and lipidology. So, how has all these different experiences shaped your approach towards cardiovascular health?
Yeah, it's interesting. And I believe God uses various circumstances in life to catalyze what you're really supposed to do when you grow up. And I'm still trying to figure that out. So when I was in physical therapy school, I actually got super sick, and it was kind of mysterious. It was kind of a perfect storm of a whole bunch of really complicated factors. And nobody could really figure it out fully. And so it really got me to fall in love with biochemistry and endocrinology, because some cool stuff there. Not cool when you're going through some really difficult times from a health perspective, but it kind of inspired me to get into this crazy world of biochemical signaling pathways. And so that kind of started things off. And then I went back to the Yale School of Medicine for PA school, actually. And then as I was practicing in endocrinology, I had a patient cancel actually one morning, and I'm always reading stuff. And so I opened up an article, and I had this just obnoxiously condescending title, like Basics of Lipoprotein, something like that. And I was like, how hard can this stuff be, right? And so I start reading this article, and I barely understood any of it. And it kind of made me mad. And so I was like, well, that's unacceptable, because I feel like, well, you cannot have atherosclerosis without one of these ApoB containing lipoproteins infiltrating your arterial abode where it doesn't belong. So I probably should know some things about how this stuff works. And I wish, honestly, that I had some humanitarian reason for investing myself in lipidology and becoming a clinical lipid specialist, and then also pursuing a PhD and studying lipid disturbances in Alzheimer's disease. But it was mainly just because I read an article and I didn't understand it, and it annoyed me. Now, from that, though, since I do care about people very deeply, because I believe that when God gives a gift, he wraps it in a person, I do believe that I've been able to hopefully help some people along the way with their cardiovascular health. And when people, I've either seen directly as a patient, or done a consult for, or have, I don't know, read something that I wrote, or have heard something I said, and it inspired them to try to get ahead of the game when it comes to their cardiovascular health, and hopefully shift the paradigm from reactionary to prevention, then that means something. And so that's really what got me into this whole charade. And what's beautiful too is I learn things every day. And I believe that learning is such a privilege. We've been given minds to think and explore. We've been given bodies to move. And both of those things are amazing, because if you stop moving, you get old. And, that's not something I strive to do prematurely. And if you stop learning, you get dumb. And that's not fun either. And so I believe that we can do both of these things, and life's fun. And then hopefully along the way, with whatever you've learned, you can help somebody. And then if you keep moving, well, that contributes a lot to your health too. And it's just more fun to move. And no one's New Year's resolution is, oh, I'm going to be, more sedentary this year. People don't say that. And I run around with kids a lot of times. I do the youth ministries at my church, and my whole goal now is just to still be that old guy who can throw down and pick up basketball and not embarrass myself or have a catastrophic musculotendinous injury or something. And those are good goals. But it's all fun, and all these things have, shaped the whatever I am now. All of that contributed kind of to writing this book, and I'm excited to kind of share my framework for cardiovascular disease with you guys.
Right. So speaking of your book, you have used a very interesting analogy in the book of, I think you use the home security systems and lipid neighborhood. So could you just expand on this for our audience?
Absolutely. And so for everybody who doesn't want to have heart attack, strokes, and dementia, which I would trust would be everyone, I say, I want you to have a great home security system, and I want you to live in a safe lipid neighborhood. Your home security system has 4 basic pillars: normal blood sugar, normal blood pressure, keep inflammation low, and don't smoke or do drugs. Those are bad. So those are your axioms. But then your lipid neighborhood is your cholesterol panel, because every ApoB containing particle, the majority of these being LDL particles, are potentially criminals that can infiltrate your arterial abode. And then the LP(a) particles are the felons, because if you pick the wrong parents with that genetic lipoprotein, those per particle are about 6.5 times as likely to cause mischief in your artery wall than your run-of-the-mill LDL particle. So, how's your home security system? We can check that. We can check your blood sugars. We can check your blood pressure and markers of inflammation and endothelial health. And then, if you're doing drugs, you probably ought to stop those. But then we look at your cholesterol panel. And we can, try to make some sense of that with our basic lipid panels. We can run some more sophisticated tests to get a better understanding. But at the end of the day, people don't live on paper, do they? And so one of my catchphrases is, got plaque? Get a CAC. And a CAC is a coronary artery calcium score. I call it the colonoscopy of the heart without the nasty pregame show. Because if anybody's ever done a bowel prep for a colonoscopy, you know how that will kind of temporarily ruin your social life and destroy your bathroom. But what's nice about this CAC is you lay down and it's a very low dose CT, about the same amount of radiation as a mammogram, so barely anything. And it tells you if you have calcified plaque in your coronary arteries or if you don't. And calcified plaque in your coronary arteries is actually a late finding in the process of atherosclerosis. And there are other, more sophisticated imaging techniques that will detect soft plaque like CT angio, and we can talk about those later. But really what we want to know is, hey, have you been broken into? Any non-zero score means that you've been broken into. And if you're a young person and you have a non-zero score on your CAC, we know from the Cardiac Consortium that age 32 to 46, you're 5 times more likely to have a premature event than somebody who should, have a CAC of 0. So that's concerning. And we don't want to just wait around for people to get worse. We want to actually get ahead of the game. And if you have been broken into, well, do you want to keep living in that same lipid neighborhood that got you broken into with all those criminals? Or do we want to maybe consider ways to move you to a safer gated community with fewer lipid criminals? I think that's reasonable. And always throughout our lifespans, are we going to be working on our home security systems? Of course. Nobody ever said, boy, this year I'm going to be more insulin resistant. That's going to be great. Or this year, I think my goal for my blood pressure is to consistently be about 220 over 120. Not a good goal unless you want to be having strokes, right? And then no one ever said, I think I'd feel better if I was consistently inflamed around the clock. And nobody ever said, this year is the year that I start doing methamphetamines. These are axioms. And so these are things that we can be consistent, because there's a lot of tribalism and there's a lot of people that say, well, cholesterol doesn't matter, but metabolic health does. And, if you focus on this, and then there's the people that say, hey, we should drive everybody's ApoB, which is a measure of particle numbers of these potential criminals, down to, basically, less than 10 or virtually undetectable, so there's all this, back and forth. And so my goal with the book is to give everybody a framework that there's going to be some agreement on. Okay. And then also I can hopefully explain from a biochemical perspective how the stuff's supposed to work, what can go wrong, and then what to consider doing about it when you've been broken into. So that's what I try to do in the book, and try to flesh out some of these concepts to make it a little more understandable, because just going by guidelines or just reading some consensus statement, well, that doesn't really tell you the why. And I think it's really critical to understand why you're doing whatever you're doing. If I'm going to take this medication, well, why are you doing that? If your doctor says, hey, I think that this would be appropriate to take this medication or to adopt this lifestyle change, well, why are they saying that? Just saying, I'm a doctor or I have this credential, that's not a good reason. Or, well, I heard somebody say this, also not a good reason. So I think it's good to have an understanding and a rationale that is actually backed up by biochemistry, by data, by genetics, all these things that will hopefully result in us having an actionable approach for our own cardiovascular and cerebrovascular health.
Right. So interestingly, you said, as you rightly said, there are two opposing schools of thought when it comes to cholesterol. There's one camp who's saying it's get it as low as possible, and there's another camp saying as long as your metabolic health is fine, cholesterol doesn't matter, you can go high as possible. So, and both of them have studies to, sort of argue with. So, why do you think there are such extreme opinions on this matter, and where do you think the truth lies?
Yeah, so I think this really gets to why do these lipoproteins exist, okay? And so to start off, you cannot have atherosclerosis by definition without one of these ApoB containing lipoproteins in your arterial wall where it doesn't belong. And then if it's in the wrong place, your body tries to clean up the mess, and it's the maladaptive immune response that results in these foam cells, fatty streaks, plaque formation, and then subsequently people can have cardiovascular events when that vulnerable plaque ruptures typically. So you can't have it without one of these, what I call mailmen going rogue. But the purpose of these ApoB containing lipoproteins, the HDL cholesterol, which they call the good cholesterol, it's not a very accurate statement. HDL is pretty complicated, and hopefully we can talk about that in a little bit. But really, the ones that we're focusing on that could cause atherosclerosis if they get in the wrong place, your artery, they're mailmen. The purpose of the ApoB containing lipoproteins is not to give you and me heart disease. The purpose is to be mailmen, deliver the mail. Okay, which is primarily triglycerides, a few fat-soluble vitamins, a few phospholipids, and then go home at the end of the day to the liver. Okay, so, most of these mailmen, they're not bad guys as long as they're doing their job, right? But if the mailman runs his truck in your arterial wall, that's a bad mailman, and then a lot of times the corrupt workforce just follows that mailman into your arterial wall. And if the mess isn't cleaned up and you're the well-intending civilians, which would be your inflammatory particles, are trying to clean up the mess but making it worse, then we could have problems on our hands. And so really understanding that, hey, the context really dictates what we're talking about. As long as your mailmen are doing what they're supposed to, that's great, and go deliver the mail and go home at the end of the day. But unfortunately, a lot of times these mailmen go rogue, and then we have a problem on our hands. And so it seems germane to address the corrupt workforce. We have multiple ways of doing that if someone has been broken into. And so that's where I think we can hopefully have an understanding of these particles, because all too often, and I teach at various medical programs, and I've precepted a bunch of medical students, PA students, MD students, and all they're taught is LDL bad, HDL good, everybody take a statin. Well, that's just so bad. There's so much more to it, but they spend about 20 minutes on it usually in their didactic programs, and they, rush on to the next thing. And so I think actually taking a step back and saying, all right, this is how these things are supposed to work. These are mailmen. Mailmen are supposed to do their jobs. Let's deliver the mail, go home at the end of the day. But what can happen if the mailman doesn't do his job appropriately? What are the factors that contribute to the mailmen not doing their jobs appropriately? And then the Lp(a), which we'll talk about in a little bit, those aren't really mailmen. That's a different situation. It's an ApoB containing lipoprotein. Its teleology is a little bit different, but it's good to know if you have that, because that is an independent risk factor beyond LDL cholesterol that can contribute to early and accelerated atherosclerosis as well. So just kind of understanding the purpose of all these things, and then what can go wrong, I think is super important, rather than just, following who shouts the loudest, whether it be in the, LDL is a toxin, so everybody should have it be 0, or the people who say, let's have an LDL cholesterol of 600 just for fun. I mean, context always matters. Context matters. And so I think that hopefully we can have an understanding of why these things are there first.
Right. So you, as you said, context matters. So in the context of poor metabolic health, or rather in the context of good metabolic health, how much of a factor is cholesterol? Say my HbA1c and all my markers are fine. It's just that I have a high cholesterol. That is often the case if you go on a low carb keto sort of diet. How much does it matter?
Yeah. And I have, lots of friends and people who adhere to a low carb ketogenic diet. What's really fascinating is some of the ongoing studies with they're referred to as lean mass hyperresponders. That's fascinating stuff. And at this point, these guys have pristine metabolic health, and they're doing CT angiography, which is kind of a CAC on steroids that will tell you the soft plaque, degree of stenosis. And so far, it looks like those guys are really, having pristine arteries. So that's really interesting stuff. The physiology, I'm really looking forward to the physiology, some of the kinetic studies, the flux studies that will show more. It will better elucidate the physiologic adaptation that occurs in lean people who have adopted this dietary pattern, and probably some of the genetic influences that contribute as well. So that's really fascinating stuff. But so for how much does metabolic health play a role? Well, I think it plays an incredibly pivotal role. And so one of my mantras is control your insulin, control your life. And so it's not just about having a normal A1C. It's also how much insulin is your body making to normalize your blood sugars. Because hyperinsulinemia, even with normal blood sugars, is associated with about a 50% increase in all-cause mortality as well. And the reason for this is because insulin is a storage hormone. If we should naturally be cycling back and forth between storage mode after you eat and then burning mode when you haven't eaten. And that's how physiology is supposed to work. But all too often, people are always in storage mode. And so if you haven't eaten, overnight, what should your insulin be? It should be low. But one of my favorite tests is to get a fasting insulin. Because if your fasting insulin is high, that's a problem. You're in storage mode when you ought to be in burning mode. And so what I like to do, the same as identifying cardiovascular disease in its embryonic state, is identify insulin resistance before it gets out of hand too. Because you'll have so many people with a hemoglobin A1C of like 4.8, their average blood sugars are fine. And then their fasting glucose is, 75 or something. And then their fasting insulin is like 25. Holy smokes. They're making way too much insulin to keep that blood sugar normal. And so by getting that fasting insulin, and there's something called a HOMA-IR, which you can take your fasting insulin, multiply it by your fasting blood glucose, and divide by 405. And it gives you a marker of, hey, are you insulin resistant or not? And so, if you're over 2, you're quite insulin resistant, and below 1, I think is ideal. So anyway, so that's a marker, that really easy test to tack on to your basic labs that will tell you that you are actually insulin resistant prior to your fasting blood glucose going up, or prior to you getting to that pre-diabetic range on your A1C, or full-blown type 2 diabetes. Because insulin resistance, pre-diabetes, impaired fasting glucose, type 2 diabetes, it's all a continuum. It's kind of being like almost pregnant. You are, you aren't. It's just a matter of how far along you are in the process. And so I like to identify insulin resistance before that. There are other ways to identify insulin resistance. Some people like to do an oral glucose tolerance test. That's a super nasty drink, I'll say. That glucola is just the worst. And you can actually get an erroneous reading if somebody is doing a consistent low carb diet, just because they're not used to be flooded with that sort of sugary substrate. So one of my actually preferred ways, because I like to maintain my friendships too and not make people drink nasty stuff. And, that's also why I just tend to sit around and talk about stuff rather than, do invasive procedures. And no one would want me to do that anyway, because I'm the worst. But anyway, I like to do advanced lipid testing. You can get something called an NMR spectroscopy or an ion mobility, and it will give you your different particle subfractionations of your, VLDL particles, your HDL particles, the size and quantity, the LDL particle size and quantity, and it requires some context. But those are actually ways that you can identify insulin resistance in its earliest stages, which starts in skeletal muscle. Jerry Schulman at Yale, hey, yeah, alumni, demonstrated that. And so you can address that with the power of exercise, and really make a meaningful you can just ameliorate whatever you're seeing as abnormal on your lipid subfractionation panel, and address that insulin resistance. And my wife's a good example of that. We got an advanced lipid panel. Her small dense LDL particles were high, even though her fasting insulin, fasting glucose was perfectly fine. A1C was fine, but small dense LDL particles are a harbinger of insulin resistance. And she wasn't exercising at the time. After 3 months of just a combination of aerobic and resistance exercise, her cholesterol, her LDL cholesterol actually went up, which just goes to show you that that's not the whole story. It's particle numbers that matter. And so her LDL cholesterol went up from like 80 to 90 or something, but then her LDL particle dropped from 1300 to 994, and her small dense LDL particles, which had been elevated, completely normalized. And that was, she didn't really change her diet, which I think she probably should have too, because, she kind of likes her dino chicken nuggets a little more than I think people ought to. But anyway, and so, but still, that was just exercise. And knowing that, hey, this is where insulin resistance starts, is skeletal muscle. If we identify insulin resistance starting and we know where it starts, then what do we do about it? Motion is lotion, movement is medicine. And that just shows you how potent exercise can be. as a tool in the true primary prevention setting, which would be somebody without any disease. Now, for our people that have, they're on their second or third, heart attack or so, oh, okay. Do I need to get all those advanced metrics? No, you've been broken into. It is quite appropriate to safely get you living in a safe, a lipid neighborhood there. And do we have, pharmacologic interventions to do that safely without compromising your home security system? Yes. And that is also why I think it's important for clinicians to understand the biochemical interactions between the various lipid lowering drugs, if that's appropriate for those patients in that context.
Right. Uh, so, for you said about NMR spectroscopy. I think at least in India that's quite that expensive and not a widely available test. So, for your average person, the lipid profile looks like a total cholesterol, LDL, HDL, triglycerides, and VLDL. So, is this of any use in that sense for the common man? What do the person look at, and what should they look out for?
Yeah. So and that's good, because I do these talks a lot. And do I encourage people to, your run of the mill person, to get all fired up and, go get an NMR? I don't actually encourage most clinicians to get them unless they want to really nerd out with me. And if people, have the means to do it and then they want to come talk to me about it, it's fun, but do you need it? Well, the answer is in general, no. Right. But what you get on your basic lipid panel, it's interesting because you really only have three things that are directly measured on your basic cholesterol panel. You've got total cholesterol, which, doesn't really matter, right? The total cholesterol, who cares? You've got the HDL cholesterol, which is called the good cholesterol, but it doesn't, HDL particles do some good things, but you don't know based on a static measure of HDL cholesterol what it's doing or not doing. You don't know. And then you've got your glycerol component that's measured. And so they call it triglycerides. In general, yeah, that based on the glycerol measurement that it would be your triglycerides. There is a really rare genetic condition called glycerol kinase deficiency where you'll have really high what looks like triglycerides, but it's just the glycerol. Really rare, doesn't happen very often. I actually never saw it in practice. But so basically, your triglycerides, your HDL cholesterol, and your total cholesterol. So we know, though, that it's the LDL cholesterol and that really, is the bulk of our ApoB containing particles that are carrying those that could end up in your arterial wall. But we're just kind of guessing. And the VLDL cholesterol is calculated, and it's calculated based on a triglyceride divided by 5. Why is that? Well, in a non-insulin resistant person in around the late 1970s, I think it was, the normal ratio on a VLDL particle of triglyceride to cholesterol, and technically it's cholesterol ester, which is the storage form of cholesterol, was about 5-to-1. Okay, well, let's just divide triglycerides divided by 5, and then that's how we get our VLDL cholesterol. A lot of speculation, right? So you can see how there's a lot of ways that you could kind of overestimate or underestimate somebody's lipid-based risk just using these metrics. And so now what I'll say, though, is I think that you can really, with an understanding of these things, make some pretty good triangulations aside from the lipoprotein little a. I think that everybody should get their lipoprotein little a measured. It's an independent risk factor. And, if you have low levels, you never have to check it again. If you have high levels, well, now but there's some ways we can operate with nuance there. But just by having your basic lipid panel, we can kind of pretty confidently assert a few things, especially when we have the person in front of us, and we have, maybe even done something as simple as a waist circumference, So triglycerides, when triglycerides are elevated, that is almost unequivocally a sign of insulin resistance. Now, if someone's triglycerides are like 1,000, 2,000, and they're having pancreatitis, that would be a genetic defect in something called lipoprotein lipase, which is how, that helps your mailman actually put the mail in the mailboxes. And if you don't have that, then, you have another genetic problem. But with subtle elevations in triglycerides, people that are, 100, 200, 300, that is almost unequivocally a sign of insulin resistance, a fasting triglyceride that's elevated. It's actually around a fasting triglyceride of 95 that's a critical inflection point. where if you do the advanced lipid tests, you see a shift to predominantly small, dense LDL particles, which particle for particle can be more likely to cause mischief in your arterial wall. Size does matter. It's not just the size per se that makes them more likely to infiltrate the arterial wall. It just becomes less avid to bind to the LDL receptor, which is how they're cleared. And it kind of has a magnetic effect, has a lot of positively charged lysine residues on them that are more likely to magnetically stick to something called negatively charged heparan sulfate proteoglycans once in the artery. So basically, it's not the size that matters, though. Any particle less than 70 nanometers in diameter can get into your arterial wall. So it's not just, oh, it snuck in there, no, it didn't. But, once it's there, it has more tendency to be retained and cause some issues. But so we can look at your triglycerides. Okay, so if we look at your triglycerides, that's a nice way to say, this person is probably insulin resistant. And when people have elevated triglycerides, they have a lot more particles than you would expect based on their LDL cholesterol, which is why something called ApoB has become in vogue, because ApoB, since every one of the VLDL, IDL, LDL particles has one ApoB 100 on it, if you know the ApoB concentration, you know the particles, and particles dictate risk. Particles dictate risk. Particles, each particle is potentially a criminal. And if you have too many of those, especially when your home security system isn't very good, insulin resistance, then the mailman might get lost on his way to delivering things. And maybe he finds that, oh, the mailboxes are full because you're insulin resistant. And then he goes and drives a truck in your arterial wall. Yikes. And so all these things do go together. And I think metabolic health and our lipid transportation system are inextricably intertwined, quite frankly. And so just looking at triglycerides, we can say, are you insulin resistant? Now, another way that we can, in general, detect insulin resistance is looking at your HDL cholesterol. Now, what I said about HDL cholesterol, a static measure of HDL cholesterol gives you no idea what it's doing or not doing. If you want to use my lipid neighborhood, you can kind of call HDL particles like the police force, because they do some really good things. HDL particles are actually capable of going to the scene of a crime where there's been a cholesterol-laden perpetrator in your arterial wall and actually taking him back to the liver, to his jail cell in the liver after he's committed some mischief. HDL particles can do that. And that's called cholesterol efflux capacity, which is really, really cool. HDL particles actually have a small role in skeletal muscle glucose uptake. Well, that's cool. HDL particles can even function as a sink for lipopolysaccharide, or if it's a gram-positive bacterium, lipoteichoic acid, and actually help people that are, having sepsis and bind those pathogens up, take them to the liver, and then that pathogen be excreted in the bile. And that's called reverse lipopolysaccharide transport. Well, that's cool too. So we know that HDL, and it has so many proteins on it that dictate its function. It may be functional, it may not be, you don't know. And so, you just don't know what it's doing, even though it does a lot of good things. But when we see a low HDL cholesterol, even if the triglycerides, the fasting triglycerides are quote normal, in general, that's because HDL cholesterol, when there's a lot of triglycerides around after you eat, the HDL particles take all the triglycerides, and then they are donating their cholesterol to the ApoB particles. And then over time, those HDL particles get all fat and fluffy with all the excess triglycerides around after you eat. Well, is a policeman who is really overweight going to be able to pass his fitness test? Probably not. And so your body recognizes it. And there's a couple lipases, hepatic and endothelial lipases, and they come in and they try to remove the triglycerides from your fat HDL particle. It overshoots it though. It's like a weight loss procedure gone wrong. And so it kind of chews up all the triglycerides, but what you're left with is a gaunt, emaciated HDL particle. So now you don't have this overweight policeman who wouldn't pass his fitness test, but you got this super, super weak policeman, this HDL policeman that wouldn't pass his fitness test for another reason. Oh, well, that wasn't very good. So what your body does, your kidney actually gets involved. It's crazy how all these organ systems get involved. There's a couple proteins called megalin and cubalin that actually catabolize and get rid of this gaunt, emaciated HDL particle that's no good for anything anymore. And so this happens over time when triglycerides are elevated around the clock. And so that's why, in general, when we see a low HDL cholesterol, now there are exceptions to this because there's always exceptions in lipidology because lipids are crazy. But in general, when we see a low HDL cholesterol, and that's why it's part of the metabolic syndrome, it means, oh, you chronically have high triglyceride spikes after you eat. And so if we want to use HDL cholesterol for anything, in general, it's kind of like the hemoglobin A1C of how high your triglycerides get after you eat. So that's what we see on HDL cholesterol. So even though our basic lipid panel is, not as complete as we'd like it to be, well, we can at least triangulate and say, I think we might be seeing some signs of insulin resistance based on your triglycerides and HDL cholesterol metrics. And then, hey, if you have high triglycerides, well, your VLDL cholesterol is going to be higher than we'd like to. And we can, easily calculate non-HDL cholesterol, which will include some of those remnant lipoprotein particles that can be particularly nefarious, because if they're not getting cleared, if they're not delivering the mail and they're not going home, well, you see those kids on the street corner when they're not going home at the end of the day, what are they going to do? Good community activities? No, they're probably going to cause mischief. And so you really want to make sure that we are minimizing those remnant lipoproteins that can be particularly nefarious, particle for particle or worse than your run-of-the-mill LDL particle. And then we have our calculated LDL cholesterol. And so, but really, what is a better measure of all these, your potential criminals in your neighborhood is going to be an ApoB or an LDL particle count. Now, ApoB is a lot more widely available. And so ApoB is a great test. And so I am all for ApoB. But just based on your basic lipid panel, and if you have a Lp(a), I can generally tell you if, unless you have a rare lipid disorder, based on your non-HDL cholesterol and all those components I just talked about, whether or not your ApoB is going to be what's called discordantly high for your given mass of LDL cholesterol. And so if you're insulin resistant and you have a certain LDL cholesterol, let's say it's like 50, right? Well, but you're insulin resistant, then I know that it's going to take more particles to deliver that mass of cholesterol. And so since particles dictate risk, what's your ApoB going to be? It's going to be higher than I would expect just based on your, lowish LDL cholesterol. And then if I know your Lp(a), well, Lp(a) also has one ApoB on it. That's another reason why someone's ApoB could be discordantly high compared to what we're seeing on your LDL cholesterol. And Lp(a) is often in the same density range as an LDL particle, but it's not captured by your basic lipid panel. So the recommendation in Europe, even the NLA here in the US, recommends that everybody should check their lipoprotein (a) at least once in a lifetime. And the reason why it's at least once is because there's a couple situations where it can increase. Statins actually do increase lipoprotein (a). Interestingly, on average, around 19%, some people more, some people less. So it's good to know. And then also the menopausal transition is cruel for many reasons. Anybody who says that that's fair, no, it's not. But one of the things that can happen in the menopausal transition is that lipoprotein (a) can go up quite a bit just because estrogen suppresses the basal production rate of lipoprotein (a). When that is lost, then your true Lp(a) colors show. So that's why it says at least once in a lifetime. And then hopefully on the horizon there will be therapeutics specifically targeting lipoprotein (a) that can help people. And then you can actually track what your level was and what it is now after receiving a specific therapeutic if those felons have been causing mischief in your arterial wall. And this lipoprotein (a), we can go into the why it's so bad more or not. I mean, but what I'll tell you is it's an independent risk factor, meaning you can have virtually a perfect home security system. And if you have a high lipoprotein (a), you can get broken into. So this is one of my best friends. He's an example of this. So this guy, I mean, he's super fit. No hypertension, no insulin resistance, even by the Josh advanced metrics, all the sophisticated, NMR. No insulin resistance, no hypertension. HSCRP is a common marker of systemic inflammation. His was like 0.4. I mean, it was no inflammation. And then no, he has never, touched a hard drug or smoked or anything. So this guy, he's super fit. Lifts, runs. I mean, the guy just looks like he descended from Mount Olympus. But his family history is no good. And we're out on a run, and I'm one of those guys who's, super obnoxious to run with because I never shut up the whole time, which probably isn't shocking to you guys after, just experiencing this deluge this morning, or this evening in India. But anyway, so, we're talking on this run and he's telling me about his family history and all this family history of cardiovascular events. I'm like, dang, man, that's no good. And so I told him, hey, get your lipoprotein little a checked and get a CAC, this colonoscopy of the heart without the nasty pregame show. Well, his lipoprotein little a was 128 milligrams per deciliter. The preferred measurement's nanomoles per liter because it's particles. And once again, particles dictate risk. But 128 is quite high. Anything over 30 to 50 is intermediate. Anything over 50 is like really high with milligrams per deciliter. He's at 128. So he's really high. And he gets his CAC back. 2,814 was his coronary artery calcium score. So if someone has a score of 300, that has equivalent risk of you having a cardiovascular event as people who have had prior myocardial infarctions. And so those are the highest risk people. They've already been broken into, and the greatest likelihood of you getting broken into is if you've had it before. 2,814. No symptoms, because he's super fit, right? And he actually had to have a 5-vessel CABG, a coronary artery bypass graft, earlier this year. But his 10-year risk calculator, which is how a lot of clinicians operate, they're like, oh, your 10-year risk calculator is 2%, which it was. His was 2.3%, and his standard measurements looked amazing. And they said, don't do anything, and his LDL cholesterol was like 110 maybe. So nothing that would be like a red flag, especially how fit he is. And it was the lipoprotein little a. So that's why I encourage people to get that checked and also get a CAC. Got plaque? You don't know. Get a CAC, right? And so that we can shift the paradigm from reactionary to prevention, because who knows? He may not even be here anymore if he hadn't had that stuff done. So that's why I encourage people to get the lipoprotein little a and get a CAC. CAC isn't as useful in a younger person because it takes time for these things to transpire. But the power of non-zero in somebody, say, under 40 is still significant because, oh man, you've been broken into early. Let's get ahead of the game. So I'm a big fan of the imaging tests that tell us if disease is present in combination with what we can understand based on our lipid metrics. And so I encourage people, hey, get your basic lipid panel and get a lipoprotein little a. If you can get an ApoB, great, but there are really two situations where outside of rare lipid disorders, that ApoB is going to be discordantly high based on, what we see on your lipid panel, and it would be insulin resistance and elevated lipoprotein little a. So if you can get an ApoB, I'm all for ApoB. It is a great test, and then you can kind of actually do a guesstimate, a pretty good one actually, of if you have small dense LDL particles based on your LDL-C to ApoB ratio, and so, so you can get a lot with an ApoB. In a perfect world, we could get all the things we always wanted, and, you can get some nerd to tell you what it all means and then carry on with your life. But in a non-insulin resistant person without elevated lipoprotein little a, for myself, right? Do I even tack on an ApoB regularly? No, because I carry on. I'm such a boring guy. I try to sound interesting, I think, but as far as my day-to-day life, I eat the same thing pretty much every day. I, haven't changed. Heavyweights aren't going to pick themselves up. And then, I run around and do I pull the levers that I think are necessary across the lifespan for maintaining the optimal metabolic milieu. And so is it going to radically change? Not really. And so, when I go to my primary care physician every year, and I don't have elevated lipoprotein little a, praise God. So do I have him tack on the advanced stuff? Every few years, just for kicks and giggles, because I'm a nerd and I like talking about it, but does it ever change? No. So yeah, that's the deal, just whatever you're doing, be consistent about it. The best diet is consistency. The best exercise regimen is what you'll keep doing. And then making sure you're sleeping, because sleeping is of critical importance, because you're just spinning your wheels if you're not getting adequate sleep. And, this is people are like, oh man, that's not what I wanted to hear. Sleep, don't eat crap and move. What does this guy know? Well, that's the answer, every day for the rest of your life. And, that's really what it boils down to. But hey, you don't know, not knowing doesn't make stuff go away, right? If you have a polyp, if you go in and for your colonoscopy and you have a polyp or two, does the guy just say, okay, well, you got a couple polyps, let's wait around for you to get colon cancer, and then maybe we'll do something about it? No, they take them out, and then you carry on. You check back in a few years, and see what's going on, right? So that's my approach with coronary artery calcium scoring. At age 40, and you can get them younger, but it's the standard across the board. I'm like, hey, at age 40, get your first CAC, fire up a 0, check back in 5 years, and so that's kind of it. It's like like a colonoscopy. And then, if this is non-zero, then we probably ought to talk about how to move you to a safer lipid neighborhood, because you've been broken into and your current neighborhood is a little rough. So I think it gives you a lot of really useful information. Like I said, it doesn't tell the whole story. If you can get a more sophisticated CT angiography, sometimes plaque actually starts in the iliofemoral arteries. There's a study called PESA where 44% of atherosclerosis started in the iliofemoral arteries. You can get a carotid IMT with plaque assessment if you have a skilled sonographer who does that and identifies some carotid plaque, because atherosclerosis can start in different arterial beds. But hey, there's lots of options. But at the end of the day, regardless, we want to be shifting our paradigm from reactionary to prevention. And we have some pretty good ways to do that with our imaging tests and by making better sense of the home security system and the lipid neighborhood that we're living in.
Very interesting, Josh. You have covered a lot of ways to identify these problems, cardiovascular risk, etc. So, can we talk about some ways in which we can bring down the LPA, as well as is there a way to bring down plaque? I mean, through pharmaceutical approaches, or are there any alternative approaches? Would you like to shed some light on that, please?
Yeah. So, as far as there is this PESA study, when there was non-coronary plaque, early evidence of non-coronary plaque, in about 8% of those people with aggressive lifestyle measures, they were able to, upon repeat imaging, actually have no detectable plaque. So can you really get your act together if you've got some plaque, and potentially reverse that with aggressive lifestyle measures without medication? I think it is possible. With coronary plaque, I don't think we have data beyond pharmaceuticals to say, hey, can we stabilize this plaque and even lead to plaque regression? There's some, we know statins do some things I don't love, as far as the skeletal muscle mitochondrial stuff and as far as the worsening insulin resistance, but it's dose dependent. So have I prescribed statins? Yes. Statins are not like the devil, and it's not like they're the cause of all existential angst, but I do believe that using a statin in combination with other medications to minimize the dose dependent side effects is really, really smart. I try to be combophilic rather than focus on whether it's hydrophilic or lipophilic, which are different characteristics of statins and their solubility properties. I say, hey, the most bang for your buck with a statin, which does stabilize plaque. If you have, if you've been broken into, do statins do a nice job of stabilizing your plaque? Yes. And so I like that. And, if you've been broken into, well, there's some pretty good data on this actually, helping your problem. However, we know that the most bang for our buck as far as reducing the amount of criminals in your corrupt workforce is the initial dose. And with every subsequent doubling, you get maybe 6% additional LDL-C lowering, and then you increase the side effects quite a bit. For instance, there was a recent meta-analysis, over 120,000 patients in statin trials. Over 5 years, new onset diabetes with a moderate intensity statin, which an example of that would be like rosuvastatin 5 milligrams, 10%. Okay, that's not crazy as far as, general population. And with a high intensity statin, which would be rosuvastatin 20 or 40 or atorvastatin 40 or 80, 36% increased risk in new onset diabetes. So, you're not getting a whole lot more LDL-C reduction there, but you're increasing your side effects quite a bit. So, do we want to do that? Well, I would say that that's not the best approach outside of acute coronary syndrome. The data is there for high intensity statin versus lesser intensity when someone has just had a heart attack. Okay. So that's a different context, right? But if we're just trying to identify things before you have the heart attack and you have evidence of plaque and we have decided that, hey, we want to start this, well, okay, let's use a lower dose and then maybe combine it with something else. Because when you have been broken into, your body fights you if you're trying to move. And we know this because people, they're living in this rough neighborhood, but this is home, darn it. I want to stay here. And so what happens when you reduce cholesterol synthesis with a statin, what does your body do with cholesterol absorption? It increases it. It's fighting you to stay in this rough neighborhood. Well, what do we do to decrease cholesterol absorption? There's a drug called ezetimibe or Zetia that is a cholesterol absorption inhibitor. And hey, ezetimibe really is super clean, very well tolerated, no real side effects. And so you can get people to wherever your lipid target is as far as their goal better, have the person tolerate it better, run into less new onset diabetes, and with that combo approach rather than just blitzing everybody with your King Kong statin dose. So I think that's a smarter way to play that game if we're talking about those particular tools. Then there's something called PCSK9, proprotein convertase subtilisin kexin type 9. And we can rattle that off without sounding like you're going to throw up, it's a special day. But so PCSK9 actually puts your LDL receptors out of order. And so I describe the LDL receptor, which is how these particles are cleared, as like that claw grabber at the arcade. And you want to, pull in, win the stuffed animal for your kid, and then go on. Well, that process with that claw grabber usually occurs several hundred times over the LDL receptor's lifespan. But if PCSK9 comes along, it puts your claw grabber out of order. So instead of recirculating to the cell surface of the liver, it's out of order. Kids are crying. People are getting in line. No one's winning the stuffed animals. People are getting heart disease. So PCSK9 is not a good thing to have around in excess quantities. Well, this goes back to my statement that your body fights you. What do statins do to PCSK9 levels? They increase PCSK9 levels by 46% when you give somebody atorvastatin 80. Okay, well, here's the thing. And so my point is, if you're going to use these pharmacologic tools, if the situation dictates that, well, they work in synergy, and you can hit several different pathways and get somebody living in a nice, safe, gated community with fewer lipid criminals, if the situation dictates that, with combination approaches rather than just worshiping at the altar of high-intensity statins, which has been what people have done a lot over the years. I think a new era is emerging here of combination therapies. And there are other therapies beyond what I just described there. Because, with that PCSK9, there's PCSK9 inhibitors as a class of medications. But, there's something else called bempedoic acid that's out there now that's kind of like a statin, but it doesn't get into your muscles. It stays in the liver where you want it to be. So that's a clever drug. It's called an ATP citrate lyase inhibitor. And I love the biochemistry of ATP citrate lyase inhibition. It's clever. But so there's all these tools, and there's tools on the horizon as far as that lipoprotein (a). But we don't currently have a medication for addressing the lipoprotein (a). As far as that goes, there are drugs in development for that. But another reason to know what your lipoprotein (a) is statins do increase lipoprotein (a). Statins do some good things, but they won't address your lipoprotein (a) if that's part of your problem. And so I think that's good to know as well, and a good rationale, again, for combination therapy, because going up and up and up and up on a statin when lipoprotein (a), the felon, is part of your problem, is that going to help the felons? No. And so I think it's just a smart way to do things. And there are other situations, there are other evidence-based medications like icosapent ethyl that can have utility in different situations. There are obviously medications that help people with their home security system. The incretin-based therapies, the SGLT2 inhibitors, other things that do have cardiovascular benefit that aren't just related to lipids as well. And some of the antihypertensives are really interesting too. And even in people without hypertension, in something called the HOPE trial of ramipril, which is an ACE inhibitor, those people actually reduce cardiovascular events even if they didn't have hypertension. So there are some other factors beyond just lipids that contribute to atherosclerosis progression. There's some really interesting things when we look at like glycosaminoglycans and other proteoglycans and other factors that potentially can contribute to the whole milieu. But at the end of the day, I do think that we can simplify it. I know we've talked about a lot of really complicated stuff. The book is much more simple than that, and it helps you walk you through in a very organized way. But I do think that, if we have a basic framework to start from, then we can, get more granular if we need to, rather than, how do you approach cardiovascular disease? Because I've asked that to a lot of my med students, and they're just like, 10-year risk calculator. I'm like, oh boy. Yeah. And then you get me wound up on 10-year risk calculators and how I think those are garbage. And so anyway, I think that, hey, if we're just looking at those 4 pillars, normal blood glucose, normal blood pressure, keep inflammation low, and don't smoke. And then we look at your lipid neighborhood and the information we can ascertain from even just a basic cholesterol panel, plus that lipoprotein(a), hey, we can have a decent understanding of what's going on there. But, the imaging that we have now, as far as the CAC being the cheapest and the most widely available screen, it can really inform our decision-making process. Because if you had a CAC of 0, the number needed to treat, and this would be in the over 40 population. So what I said about, the CAC of 0, statins, if your coronary artery calcium score is 0, the number needed to treat, meaning that somebody would actually benefit from this medication, ranges from 3,571 to infinity if your coronary artery calcium score is 0 in that age population. What does that mean? Is it really helping you if your CAC is 0 in that situation? And then obviously there are rare exceptions. There are people with profound amounts of soft plaque and things, but this does not happen that often, okay? And so I think that we can really just do a better job with one extra test, I'd say the lipoprotein(a), and then our imaging techniques as far as, you got your coronary calcium score, and then we're doing across the board globally in getting ahead of the game.
Right. So coming to statins, as you rightly said, it's being widely overprescribed, right? It's come to the point where the doc says, you just take statins. It's come to that point at this moment. So who really needs it, and at what point and what arguments can you put forward, right, as an average person to the doc, like, hey doc, I really don't think I need this at this point. So uh, who does actually need statins? And there are a lot of side effects that is known about statins as well, like muscle pain and a lot of stuff that's been floating around, some of them well documented. Obviously it's dose dependent as well. So who really needs it?
Sure. I'd say if you've been broken into, right? If you have a CAC above 0, those people, there's benefit there as far as reducing cardiovascular events. If you have a CAC of 0, there isn't good data to support you using this, and then of course, the age matters, and so the other situation that is tricky is a kid has heterozygous familial hypercholesterolemia. Kids with homozygous familial hypercholesterolemia, as far as they don't have any of those claw grabbers at all, they will be in the cath lab by age, 8, 10. I mean, that's a terrible disease, and that's a different disease. Fortunately, it's very rare, 1 in 360,000 to 1 million. And those kids need to have aggressive early interventions. Okay, that's a different context. But you're run-of-the-mill person, okay, if you have a CAC of 0, if you're 40 and up with a CAC of 0, why are we even talking about lipid lowering therapy, really, based on our data? Now, there is an argument as far as, well, it takes a long time for these things to happen. It's like, they call it plaque years versus pack years of smoking, because it's always better to, stop smoking today rather than, keep smoking and hope you don't get lung cancer. I would say that argument can be okay sometimes, but breaks down because smoking is unequivocally toxic to your physiology. Even if you don't get lung cancer, is that impairing your ability to perform? Yes. It does all sorts of terrible things. Is LDL cholesterol inherently toxic? Is an ApoB containing lipoprotein inherently toxic to your physiology? Well, no. Mailmen, right? Deliver the mail, go home at the end of the day. Because people that lack the capacity to synthesize ApoB containing lipoproteins, it's called A-beta lipoproteinemia. Do they have very good lives? No, they have horrible malabsorption, horrible neurological issues, and if they don't get help, they die. So no, these things are not unequivocally toxic. And conversely, if you don't give someone the option of cigarette smoking, Yeah, no, that's actually a good thing. So I would say that the plaque years versus pack years does break down, even though it can be true in certain contexts. And so my stance, and obviously there are exceptions, but in general, okay, you're the 40 and over crowd, you have a CAC of 0. Awesome. And this is asymptomatic people, okay? Hey, let's focus on your home security system, which we always are anyway. And then are you going to benefit from any lipid lowering therapy? No. The data just doesn't support that. Now, if you've been broken into, okay, and there's been a break-in, you have any plaque in your coronaries, do you prefer that plaque to be stable or unstable? I think stable is better than unstable, given that 2/3 of heart attacks happen in a non-stenotic, non-occluded vessel. So you're fine till you're not, and then that vulnerable plaque ruptures, and then you have the big one. Okay, so can we stabilize plaque? Do we know from these really sophisticated intravascular ultrasound studies that statins have some plaque stabilization properties? Yeah. Okay, so that's a situation where you would say lipid-lowering therapy would be a prudent recommendation. And then can you even further stabilize that plaque and even regress the plaque? Actually kind of reverse the trajectory of this disease? You can. And the studies of some of the PCSK9 inhibitor monoclonal antibodies, the big guns, yeah, you even get more plaque stabilization as far as the vulnerable plaque features, which would be presence of macrophages, a thin fibrous cap that's more prone to rupture, and then also the presence of a lot of lipid. If you've got fat in your plaque, it's bound to crack. And so you don't want those things. And so you get further stabilization with the PCSK9 inhibitors. And then you can even see plaque regression as far as the overall plaque burden as measured by percent atheroma volume. So I think that's positive, but that's the context where the person has been broken into. And so let's get you living in a safer lipid neighborhood. And so I think those are the people that, we got all sorts of data to support that. But, and the person with no disease, and, the younger crowd's a little bit tougher to deal with just because we can't project all the way in the future always. But hey, I think that we should always focus on our home security system and then just know the factors and try to know some stuff about our lipid neighborhood. But as far as the pharmacologic intervention, we know that the people who have been broken into benefit. But other than that, there's not much there. And so I'm not of the opinion certainly not the opinion that, statins should be in the drinking water, or, everybody should have a physiologic LDL cholesterol. That's said a lot of times because when you're a baby, you're born with an LDL cholesterol of 22 to 44. And so certain people, and I'm friends with everybody, right? And I think it's healthy. I actually have some degree of, disagreement and conjecture, and I think it's good. But, you're born with an LDL cholesterol 22 to 44. So the argument is, we should have people, with that or the equivalent ApoB around, 20 or 30. You're born with a blood sugar like 30 a lot of times too. And is that what we strive for? Not feeling real good if your blood sugar is 30. You know what your ApoB and your LDL cholesterol is at 2 months of age? Because your liver hasn't developed fully, right? At that point. And the liver is secreting a lot of these lipoproteins. Your LDL cholesterol at 2 months of age is actually 65 to 80. This is the Copenhagen Baby Heart Study. And your ApoB is around 73. I would say if you want to say what's physiologic, I'd say that would be closer to physiologic, right? Rather than what you're born with, because, that's a different context once again. And so I think that argument, it falls apart a little bit. Now, can you safely, if you intelligently manipulate these biochemical signaling pathways with pharmacologic interventions, can you safely get somebody with an LDL cholesterol of even, less than 10, if you do it the right way? Yeah. And can that person have minimal to no adverse effects for their home security system? Yes, actually. And some of the long-term studies of the PCSK9 inhibitors, which just enhance clearance rather than perturbing any sort of synthetic pathway, you can do that. And if the context justifies it, as far as this person has been broken into repeatedly a lot of times, well, I think that that's not unreasonable. But just for your run-of-the-mill person, who's wandering around, for myself, right? I'm, going and, running around and doing all these things. Do I feel a compelling need to drive my LDL cholesterol to, 5 milligrams per deciliter? Nope, I don't. And so I'm going to keep taking my creatine and magnesium and trying to crush it at life. There you go.
Right. So one of the things which statin haters, if I have to put it that way, say is that statin extends your lifespan by 3 days or 5 days or something. I don't remember the exact number, but that's the argument they make against statins.
Yeah. And those are always interesting things. And once again, the context matters. And when you're utilizing arguments like that, it really does. If people don't want to believe in whatever the drug is that you're talking about, oh man, that's great ammo. We always like confirmation bias. I'll say the limitation of statements like that are they treat clinical trials, which are usually a couple years, right? So 2, 3, 4, 5 years. They treat it as if everybody dies the moment the trial ends. And so it would be like, okay, we had, some group here that benefited from the drug and would have otherwise died. We have another group here that maybe was on the drug and shouldn't have been on the drug. And then we have other people that weren't on the drug who didn't need it anyway. And so you have this big pool of people there. And then you say, okay, well, can we make sense of this? And a lot of times, some of those studies that they've actually used it benefited by 3 days, they plotted it on like Microsoft Paint and counted the pixels. And so I'm not exactly sure about the statistical methodology on that anyway. Now, do I think a lot of people are on a statin and shouldn't be? Yes. Do I think certain people should be, and it's not just a statin, right? We have other options now. If the year were 2004, then we would have to bend over backwards to get you on some dose of a statin, given that was kind of the best evidence-based tool if you've had a break-in. Well, we have all sorts of other options now. And so if you can't tolerate statin, that's fine with me. I can play this game other ways, and I can do it in a way that won't jeopardize your home security system, quite frankly. So that's cool. And so anyway, but the limitation of those analyses, which are quite sensationalistic, is they treat those trials like, oh, everybody died the moment that the trial ended. Well, no, there's people that lived who, let's say that there's a person, which we don't know, but let's say there was a person who was on the medication who would have otherwise had an event, but because they were on the medication, they didn't have an event and they continued to live. You're not going to capture that at the end of that trial, are you? And so that's really where it becomes individualizing your approach. When you're looking at anything from a population level, when you're looking at these things from just clinical trials, there are limitations because you're looking at this person for the whole life, and that's one of the limitations of clinical trials too, is because, this disease, atherosclerosis, I mean, it can even start when you're born if you pick the wrong parents. There are actually, unfortunately, kids who were stillborn of mothers who have familial hypercholesterolemia who picked the wrong parents. They actually have the beginnings of fatty streaks, on those, in the stillbirths when they actually did the autopsy. So there are certain genetic factors where it's like, well, bummer, you picked the wrong parents, like my buddy, who you got broken into. Okay, well, what can we do about it? And so there are certain situations in this fallen world that do dictate the, necessity of certain pharmacologic agents. But for the mass public, control your insulin, control your life across the lifespan. Make sure the mailmen are, delivering their mail appropriately. And then, if you pick the right parents and you pull the right levers, are you going to need any of these lipid-lowering therapies?
All right. So one of the things which those who tune into this podcast will definitely ask is about saturated fats. Like there'll always be there's someone saying saturated fats impact your lipids very badly. So I need some clarity on this.
Yeah. So this is a very interesting topic. So saturated fat, I don't believe is the enemy. Now if you are eating saturated fat as part of a diet that consists of other horrible things, well, that's probably bad. But and in excess, I mean, extreme dietary patterns of any sort, I don't know. I'm not sure that's always the best thing, but context matters. So what I'll say about saturated fat, it decreases the LDL receptor expression in your liver. Remember, this is the claw grabber. This is how you pull particles in. And this is, there are some unique ways in which cholesterol within the cell is either stored or is in its free form. So cholesterol is in an esterified form within your cell, or it's in its free form. And so saturated fat is actually not the preferred ligand for something called ACAT. And so ACAT, there's various isoforms of ACAT, but in your liver, it's called ACAT2. And so whenever you are storing cholesterol within your liver, it actually prefers an unsaturated fatty acid to replace the hydroxyl at the third carbon in the first ring to esterify and store that cholesterol molecule. And so it prefers an unsaturated fatty acid. And so if you're having a lot of saturated fatty acids around, you're going to get less esterification of that cholesterol. And so you're going to have more free cholesterol migrate to the plasma membrane. And so when there's more free cholesterol migrating to the plasma membrane, it's very, very tightly regulated. And to have excess cholesterol in your cell, that's no good. And so your cell's going to commit suicide and explode, And so that free cholesterol migrates to the plasma membrane, and it downregulates what's called the sterile regulatory element binding protein 2. And so the consequence of that is you have decreased LDL receptor expression to the cell surface. Okay, that was super complicated. But basically, hey, when you have that sterile regulatory element binding protein 2 downregulated and you have decreased clog grabbers out there, you're going to be pulling in less particles. So can saturated fat can you see an increase in your LDL cholesterol if you are ingesting a lot of saturated fat? Yes, that is possible. And that does happen in general. But is saturated fat itself, the problem? Let's say somebody is, crushing it at life, non-insulin resistant, and eats, steak or whatever. Do I think that's problematic? No. But what I'll say is there are multiple dietary patterns that can work for people, Okay. And so I don't think that you need to do this or this or this. What I do think you need to do is control your insulin, control your life. And what I think is, in my general approach, is prioritize protein and eat real food. All right. When somebody grabs a corn dog, they don't think to themselves, I'm consciously making a really good health choice here when I'm eating my corn dog. When someone's drinking a soda, people aren't like, you know what, I'm cleaning up my act this year. It's 2025. And I've had a real good start. I've been drinking 3 24-ounce Cokes a day. No, you know that you're not doing something that you should be when you're just eating pure crap or drinking it. And so prioritize protein, eat real food, control your insulin, control your life, whatever that dietary pattern looks like. Okay, there are multiple dietary patterns that can work, depending on the context. So, I think that's kind of where I stand there. The physiology of saturated fat versus unsaturated fat is interesting as far as what it's doing, especially with the intracellular esterification or lack of esterification of cholesterol. I think that's really interesting. But also, I think that most of the time, if there isn't some really far extreme one way or the other, I don't think it's having just a particularly potent effect on what's going on.
Very interesting, Josh. Just a quick time check, like how much time more do we have?
Yeah, I have some other meetings here. I've got about 5 minutes or so, if that's okay with you guys. I could go all day. I love this stuff, but
We'll probably have another session in the future to cover cholesterol, brain health, Alzheimer's, because
because we haven't even touched on that. And that's a great topic, and that doesn't, we don't want to rush that. And so because I'd love to come back if you're interested in round 2. That usually means that we at least had some fun.
Yeah, of course. No, we had so many great insights on cholesterol, on lipids, amazing new information for our listeners. And the book, it's very interesting. It's going to cover these topics in a very relatable way. So tell our audience how to, keep up to date with your work, where to reach out, and how to buy this book.
Yeah. So, like I said, it's called The Home Security System and the Lipid Neighborhood. And you can just search it on Amazon. And like I said, I am planning actually, as soon as I get this has an obnoxious not for resale on it. So I'm not going to do that, but I'm supposed to get the copies that don't have the not for resale on it today. Once I look those over and make sure that they didn't do something weird in the printing, I am going to actually, as a Valentine's Day surprise, release that, and it should be available for order within the next couple of days. So hopefully by Valentine's Day, because of the heart, you can pick up this copy. In the US here, the ebook is available for pre-order right now, which is $9.99 if you're a Kindle person. That will be released February 18th. So it's locked in on that date. But I anticipate that you will be able to get this in your hands before Valentine's Day, if all goes well. So stay tuned on that. But you can just, search it on Amazon at the very latest. February 18th, it'll all be out. But I actually anticipate that the hard copy will be out prior to that. In the US, it's $14.99. My whole goal is not for this to be some lucrative endeavor. It's to cover the cost of production and then get it in your hands, because I think that you'll have some fun reading it. And I actually think that, you can have something actionable to get ahead of the game and to prioritize your cardiometabolic, cardiovascular, and cerebrovascular health across the lifespan. That's my goal for all of us.
That's awesome. Thanks, Josh, for your time on the Healthy X Sundays podcast. We had a lovely time talking to you, getting so many lovely insights. Love to have you back for the cholesterol and brain session sometime in future. And with that, we want to wish you all the best for your book and the awesome work you're doing. So thank you.
Thank you so much.
Dave?
Right. It was an amazing session. And the takeaway for me was that last bit of line you said, prioritize protein and eat real food. That's simple as that.
That's how it goes.
All right. Thanks, Josh. Take care.
All right. Take care, guys.